Dr. Chuck?
My name is Dr. Cakic. Everybody knows me as a Chuck. I'm a specialist orthopedic surgeon who decided about 15 years ago to subspecialize in the hips only. And following my fellowship that I did with Professor Weber, which I'm seeing as a pioneer and doyen of hip surgery in South Africa, I learned many ways of dealing with the hip and hip complications. And in my evolution as a hip surgeon, I came across a hip arthroscopy, which going away from the replacement. And at the same time, I came across of idea of, as a preservation surgeon that I see myself, using the more minimally invasive procedure, which is anterior approach. And that is my approach that I use in, I would say, about 90 to 95% of the time in my patients. However, I believe that if one wants to be a subspecialist, has to have a knowledge and ability to do any approach to the hip and decide which approach is the best for that particular patient. So that's why I work with Dr. Pietrzak, because he is far better in posterior approach to the joint than myself, and we're sharing our experiences for the benefit of patients.
I'm Dr Pietrzak. I'm an orthopedic surgeon who works at the Joburg General Hospital, which is a government hospital in Johannesburg. I've been experienced in doing anterolateral total hip replacements, and then in a year's fellowship in the United Kingdom, I was introduced to the posterior surgical approach, which is currently my standard approach. However, I am working and learning from Dr. Cakic because I certainly do have an interest in the direct anterior approach, which is a minimally invasive surgical approach in between the muscles and sparing both nervous planes.
Why do you prefer the anterior approach? Why did you go into the anterior approach?
So why did I decide to turn, which my bread and butter in the past was a lateral approach and so-called hardage approach, was purely because my mind was changed towards preservation. Okay. And being exposed to the hip arthroscopy and being exposed to the saving of joint as much as possible, I start doing the approaches, starting with the posterior, starting with the lateral approach to make it as smaller and smaller and smaller, to try to do the less invasive and more rehabilitatable, if you will. Mm-hmm. And then we did the same with the posterior approach. And eventually you realize that size of the cut is actually not definition of minimal invasive. What actually is important, what you do underneath the skin. In anterior anatomical structure of the hip, we have an interval where we can go between the muscles and we can approach the joint without doing a damage to the musculoskeletal system.
My posterior approach is only a 9 centimeter incision, but I do release muscle. So yes, you do have to release the piriformis, you do have to release these short external rotators, and you do release a small amount of your quadratus femoris, which means that there is some weakness while things are healing.
But you do attach it again.
But we'd have to, but we reattach everything, and this is where the big difference now comes in, is obviously once you've taken a muscle off or detached a muscle and reattached it, it takes time for that to heal.
Yes.
And that's why the feeling and the belief around the world is that the lateral and the anterolateral and the posterior approaches are less good than the direct anterior approach early on, because there is no muscle detachment with the anterior approach. So patients are up, they're moving, they've got a better gait early on. But as time goes by, and the belief is there that after 2 years, there is no difference.
Why do you have then surgeons that prefer one approach versus a different?
Because each university in our country has a different philosophy. If you go to Free State, you're going to do only posterior. If you go to Wits, you're going to do only lateral. If you go to the Cape Town, you're going to do either posterior or lateral. Only recently we start actually introducing an anterior approach as a part of the basic training.
How long does it take for the prosthesis to integrate with the bone?
Most of the prostheses in the market are covered with material that produce effect of bone growing into the prosthesis, and that is taking about 3 months. So in my protocol that we design and what we're using in our hips is that we're not allowing any sporting activities. for the patient for the first 3 to 6 months. We do assessments, again going for the physiotherapy, biokinetic and everything, which is essential part of the whole protocol. And then we allow them to start going slowly into the sports only after 3 months, waiting for that biological effect to happen.
What are the complications, the major complications with the anterior approach?
In specifically anterior approach, there is a one nerve which runs in the front of the thigh, which is called the lateral cutaneous femoral nerve. And that damn nerve, in any single person in the world, has a different pathway. It's not one nerve like we know that median nerve is always there and you've got to always find it. That nerve can be spread it in the 5 branches, can be spread it in one, can go anywhere. So you never know when you do the cut, then are you going to nick one of those parts of the nerve, which can leave the patient with a feel of numbness in the skin of the thigh in a certain area. And that is one of the biggest criticisms of anterior approach. However, I don't see it as a complication. I'm seeing it as a side effect, because there is no person on the face of the earth that had a knee replacement that doesn't have a sensory loss, because all the nerves are running across the knee and you're doing a longitudinal cut. So if you tell the patients about it, they don't even mention to you anymore. Again, it's about communication. What you expect from that surgeon.
Dr. Pietrzak, what's the complications with the posterior approach?
Well, I think the biggest complication with the posterior approach is hip dislocations.
Okay.
Because you're actually removing those posterior structures which you're preserving in the direct anterior approach, and therefore things can pop out.
And is that just in the first couple of months?
So I think that's initially, and then once everything is rehabilitated, then it decreases. And in the literature, the complication rate with regards to dislocation is far higher in posterior approach than it is in the anterior or the lateral approach.
How does a patient decide what to do and where to go to? Is it always good to have a second opinion and then the patient just sort of decides what's going to work for them?
Jurek's going to go after me with the same question, but my opinion, it's not your choice. Where your decision comes into it is a trust. Now, you need to know who you're going to trust. And you need to have the trust in you that that person who is going to be your surgeon is going to do the best for you. Is that going to be anterior, posterior, lateral, upside down, way forward? Irrelevant. You want to have the best results for you. And that's my answer to your question. The decision that I'm going to make as a surgeon, again, is going to be the best for you as a patient. In my hands, as I said, about 95% of times is an anterior approach. But there is a patients that are not for anterior approach, and I'm telling them straight away, this is not for you. There is psychological component that is extremely important. It is a long-term relationship. Once when I put the hip in, you become my patients for the rest of my life, or yours. Every problem, every complications, everything in the future, it's between us.
So choose your surgeon, not your approach.
I think so. What do you think?
So everything Dr. Cakic just said, I agree 100%. I think for anybody listening out there, I think we've all got to understand that the approach is actually a small part of the whole procedure. You know, the approach is important and the approach helps you get there. But the surgeon also has to decide what implant he's using, what bearing surface he's using. We've also then got to look at, well, what happens in the outcomes. Patients' expectations actually is the biggest determinant of a patient's outcome. So if a patient has a hip replacement and they think, oh, I'm going to go and start gym 1 week later and I'm going to start lifting 150 kgs and then I'm going to run the comrades within 6 weeks, they're never going to be happy after that replacement and they're actually looking for trouble. So I have to concur entirely. And then also patients have to realize that it doesn't just stop and end with the surgeon. The physiotherapist, the biokineticist, the anaesthetist has a big role. It's essential that patients keep up with this rehabilitation. Your hip is there with you for a lifetime. So you've got to treat it well for a lifetime. And I think it's essential that the physiotherapist is simply a bridge to your biokineticist. The physiotherapist gets and packages your hip to a point where the biokineticist is safe enough to build up and help you build up those other muscles to allow you to go back into your life, because that's why we're doing this whole procedure, is to give you back your life.
I think also that what is important to understand, social background of the patient. I can talk only about what I see in private practice in South Africa. If I'm having an 80-year-old lady that wanted to have a hip because she's in pain, and she's not interested in doing anything except being at home, then you're going to have a different post-operative care
Yes.
than for somebody who is 50 and he wants to go and play golf and cycle and this and that.
Yes.
And I think that one thing that we start breaking it, and I hope I broke that mental block in the people in my practice, is that historical thing that hip replacement was for the old people and hip replacement was for the pain relief.
Yeah.
And you are never ever able to do what you were doing it before hip
After you've
replacement.
had it.
And this is a perception in the people in the world.
Yeah.
And this is what people ask me: how long my prosthesis is going to last? Am I going to be able to go for walking? Am I going to be able to play tennis, and so on and so forth? So this is again communication and education. That perception of the hip replacement in 90s and 80s or last centuries are completely different now.
Yeah.
It should be different than perception to the hip replacement. The hip replacement is happening in 10% of the population of the world. That's it. Every person who is born has a 10% chances to end up with a joint replacement by age of 65, period.
I think the last thing I want to just discuss is high impact stuff. Can they go back to running? You mentioned tennis. Can they do those type of sports after hip replacement?
There are certain limitations because you do have a piece of metal.
Yes.
Now, is that change, you reckon, correct me if I'm wrong afterwards, but is it a change in the last 30 years? Yes, it is. So officially, as a surgeon, I tell my patients you should not do this and this and this. But I have some people that are in comrades on it. Shall we call them nutcases? You can. Shall we call them the people who enjoy their life? Absolutely. They know, I told them, if you do that, you have these chances that go wrong. If you're prepared to take those chances, be my guest, and when you get your gold medal, send me a picture so I can put you on a wall.
Just on that point, I think for anybody watching this, there's different risks. So when you say go back to sport, there's the risk that you're actually going to wear out your head that's rubbing on your acetabular. So I think what's definitely happened over the last 30 years, and in fact Dr. Cakic just done his PhD on this, is that the bearing surface has changed. So the head rubbing on the cup. So that has changed and that has certainly improved. The next big worry that you worry about is that by running on this, you're actually going to loosen that prosthesis and the bone that's grown onto the prosthesis. And that's why, theoretically, what we want is in younger patients, we want to use an uncemented prosthesis because then the bone has grown onto the prosthesis and theoretically it's a lifetime integration. And then of course the next thing that any surgeon is petrified of is dislocation. So if you go back to judo or Brazilian jiu-jitsu or something like that, you're going to get into a position where you're going to pop the hip out. And then the last thing of course is you're worried about periprosthetic fractures, where you're going to do something high impact and you're going to fracture. So I think things have evolved and the materials that we're using have improved and those have changed. But have we got the perfect implant? No, we certainly don't. But I think I like Dr. Cakic's philosophy is that do the best operation for that patient to allow them to make those decisions.
Thank you so much. I really appreciate you guys taking the time.
My pleasure.
Thank you very much.